Okay, whoops. Okay, guys. I look like Mr. Clean's been beaten up. It's the lighting, I swear. Okay, so this is your asynchronous assignment for tomorrow, the 21st. And it's a PowerPoint that we probably wouldn't have gone through if it were not for the fact that we're staying home for probably a couple of days, if not the week. So that's good though. The PowerPoint comes from my own research and also from a different book that we no longer use, but it's still it's quite useful. Unlike most PowerPoints, it's a little bit it's less wordy. It's less wordy. So okay, I am going to let's see, share my screen. Where'd you go? There you go. And I'm going to turn off this because, guys, I'm going to, well, no, I was going to flip the computer over to tablet mode, but I don't need to do that with the PowerPoint. And but I am going to keep it off. God, I don't know what the hell happened to me there. Okay, so most exams, you're actually going to start at the femoral artery, work your way down, just like we've done in class now. But it's not a bad idea to take a look at the aorta and the iliacs. They can be a little difficult depending on the body habitus and everything. Not a bad idea. If they have disease in the legs, it's all connected. There's probably going to be disease up high, and it helps to let the doctor know. Anatomy, internal and external iliac arteries, of course. Oh, let me get, okay. Hello, come with me. It will not pass the barrier since that's interesting. Okay, forget it. Forget it. You're going to have to see this tiny little cursor here, but you know where the external, the common iliac arteries. I really should have said common. Oh yeah, look at that, internal and external, but I missed the common. So common, once this internal iliac artery comes off, then it's all external down to this little white line. I don't know. Hopefully you can see my pen here. That is the inguinal ligament. We don't really see the inguinal ligament with ultrasound. You think you would, but I mean, I suppose if I really search for it, I could find it. But it is, it's basically at the crease of the leg. So, common femoral, deep femoral, femoral. You guys know this stuff. Popliteal artery. So it goes. The femoral artery goes deep through Hunter's canal. And we know from looking at the veins that could be a difficult part to follow. And then it becomes a popliteal artery. And the first really thing that you see coming off is actually not the anterior tib, but the gastrocnemius artery. So if you see an artery going specifically right into the middle of muscle, that would be the gastrocnemius. The anterior tib will be the next one to come off. It usually comes off at a pretty acute, no, I shouldn't say acute angle, more like an obtuse or almost a 90-degree angle. And I'll remind you, you're looking at the leg upside down. So anterior is going to be going straight down on your screen because that's where the anterior is. Now, this was a great picture, but it had a couple of mistakes on it, so I had to scratch something out there. But as we come down, this is a posterior view. So we've come down from Hunter's canal. We've become the popliteal artery here. You know, I can't trust that you even see that. Let me try this again with another. Oh, the arrow comes down. Okay, that you should probably see. So popliteal artery. At this point, they're not showing it because it's not considered part of the deep arterial system, but the gastrocnemius comes off at this point. And then the anterior tib. See this showing, this coming off at as kind of a low angle. Well, a lot of times it comes off like point, goes straight up and then down. And it will define the anterior tibial artery, just like the anterior tibial veins. You're going to look at the lateral side of the shin bone, the tibia, and it will lay on top of this fascia, the fascia that runs from the tibia to the fibula. So it'll lay somewhere on top of that fascia. So that's where you're going to be looking for that one. In veins, we generally skip the anterior tibial veins. In arteries, we do not skip this. So go ahead and look for this guy and follow him. Now, the tibial perineal trunk, we're starting to get out of behind the knee and into the calf. If we could see the muscle's starting to really grow right here. Things get a little difficult to find, but you might be able to find a little bit of the anterior tibial perineal trunk. Chances are you're not going to go far enough down to see the split between the two. So fibular artery is an older name. Perineal artery over here, posterior tib over here. It is posterior to the tib. Remember, this is a posterior view, so things look a little bit different as far as our anatomy goes. And let's see, and they said the perineal becomes, where'd you go? There you are. The perineal becomes a dorsalis. No. The perineal splits off and becomes so small that it's not worth us following. The posterior tibial artery is the one that becomes, the posterior tibial artery comes around the medial malleolus. I just misspoke. The perineal, I didn't really misspeak. The perineal certainly does not become the dorsalis pedis. The dorsalis pedis is actually a branch, or the end of the anterior tibial. So that it's still a mistake. I had a slight brain fart there, but I'm okay now. Posterior tib and lateral plantar. We don't have to worry about that. This picture. So I isn't spelled with an I, is it? So I misspelled I 3 times in a row. Well, anyway, life goes on. Okay. What did I do? Let's see. I did something. There we go. Don't know what that was. Okay, posterior tibial artery passes the medial ankle and becomes eventually the plantar artery. Don't worry about that so much, just that the posterior tib passes the medial ankle, and that's so the medial malleolus is another way of saying that, and that's where I suggest you start your exam. And it's also, if you're doing ankle brachial index, an ABI, that is one of the arteries in the ankle you look at when taking blood pressures. The anterior tibial artery passes over the top of the foot to become the dorsalis pedis. That is the other artery we look at. And the perineal artery passes laterally, but it's quite small, it's not imaged, so we don't really look at that guy so much. Let's get back to my little arrow guy here. So the posterior tibial artery comes around the medial malleolus, becomes a plantar, but we only care about it right here along the medial malleolus. The dorsalis pedis artery, this is the anterior tib, dorsalis pedis. So it just turns into another name for no reason other than to drive us crazy. Okay, I need to pause because there's something not quite right with this. Son of a bitch. Okay, still having a little issue, but I don't know. So at rest, our arteries, 20 to 25% of skeletal muscle capillaries are open. That means that 75 to 80% are closed. High resistance flow is seen. Triphasic waveform is normal at rest. And so this person has mostly a triphasic, even a quadriphasic waveform, but we just call it triphasic. Some people are getting in the habit of calling it multiphasic too, although this specifically is very much a triphasic waveform. The reason they're going with multiphasic is because there's a lot of confusion between phases, between what to call what. But this is a normal resting artery. After exercise, capillaries and muscles, 100% open. So another, all of them open. And this happens very quickly. Low resistance flow is seen. Dermal capillaries vasoconstricted, so the skin actually constricts a little bit, the skin capillaries. The mesenteric arteries are vasoconstricted. You don't need to be digesting food when you're running for your life. Blood volume to the legs increases dramatically. So this is normal flow after exercise. And like I said, guys, this happens really fast. Your body reacts to exercise very quickly. Other triggers for vasodilation, this is vasodilation. This is, of course, one other thing, we could say this is no longer a high resistance. I mean, it's kind of high resistance, but it's not nearly as high resistance as that. As the previous. Other triggers for vasodilation, open up the vessels, let all the blood in. Abnormally low O2 in muscle tissue. We're going to come around to that again. Abnormally high CO2 in tissue. Increased lactic acid. Epinephrine, hormone epinephrine, and nitrous oxide. Nitrous oxide. I'm not going to go there. I promised Melissa I wouldn't go in those directions anymore. But nitrous oxide has other pleasant effects on the human body. Anyway, arterial occlusive disease, occluded arteries, collateral vessels cannot provide blood needed. Why did I write that? Occluded arteries, collateral vessels cannot provide blood needed. So, well, sometimes they can't. Collateral vessels, that's what they're there for. Well, that's what the body uses them for, is to provide the blood. Stenosed arteries. Now let's go back to Bernoulli's law. It says that an increased flow across the stenosis only serves to further drop blood pressure. So an increased flow. In other words, when you start to exercise and you have stenosis in your legs, it gets worse. Even if you vasodilate and more blood is getting into those legs, it actually gets worse because the blood pressure drops to an even greater extent. So hypotension is decreased perfusion along with decreased volume, both contribute to insufficient O2. So hypotension, low blood pressure is not good. At least, I mean, there's healthy low blood pressure and then there's really low blood pressure. The reason you have a hard time breathing at 14,000 feet, Pikes Peak, which used to be out my back door, is not so much that there's not enough oxygen, it's that the air pressure is so low. So that's why, and by the way, I drove to, because you could actually drive to the top of Pikes Peak. I drove up there. I'd been living in Colorado Springs for 7 years at the time. I was well acclimated to 7,000 feet, which is where I lived. Went up to 14,000 feet. The world was spinning. I did not do well at 14,000 feet. So I guess high mountain climbing is out of my bucket list there. Claudication, to limp, intermittent claudication, pain, fatigue, cramping in the calf, thigh, buttock after only a short walk, and then is relieved by rest. That is an indication. It doesn't necessarily mean that a patient has peripheral arterial disease. They might come in with claudication symptoms, and you're going to be testing for that. It could end up to be nerve damage. It could be arthritis. It could be other things going on. Severe disease, vasodilation at rest. Vasodilation. So I use the same picture here, but it's the same idea. With severe disease, the muscle beds are always O2 deficient. And so the muscles themselves are always giving information, giving signals back to the arterioles, hey, we need more blood, we need more blood, we need more blood. So those arterioles are always vasodilated, even when you're laying down, even when you're resting. So when you have a patient who is at rest, who is warm, who's been laying there for 15, 20 minutes, and they continue to have blood flow that looks like this, that's an issue. That tells you that they have severe disease. So this picture could be post-exercise, but it also could be no exercise in someone who has severe disease. Mild arterial disease, I don't know why severe came before mild. I might have my slides out of order here. Could be asymptomatic. You may have reduced pedal pulses, which, by the way, I don't know how doctors and nurses do that. I am not very good at finding pulses. Mild decrease in ankle pressure with exercise. Did we talk about that last time? I remember, I think we did. So let's just make sure we understand. Decreased ankle pressure with exercise. What did I just say about Bernoulli? The faster you exercise, your heart starts beating harder, your arterioles open up, the blood starts really rushing into your legs. It only serves to drop the blood pressure even more beyond the stenosis. Bernoulli does not give up just because we go for a walk. It will continue to hurt. Continue with moderate arterial disease, asymptomatic at rest, significant decrease in echo, significant, moderate, what was the first one? Oh, mild, moderate. Asymptomatic at rest, significant decrease in ankle pressure with exercise. So when you do an ABI, an ABI is going to give you a general idea, but an ABI plus exercise stress test is going to tell you even more, because you're going to see a significant decrease in ankle pressure with that significant increase in blood flow and intermittent claudication. Severe. Yeah, I guess my slides are slightly out of order. Weird. Night pain. In other words, you have a hard time sleeping. Of course, I'd have a hard time sleeping with that dragging against my sheets, I think. Night pain while supine, somewhat relieved by sitting up. In other words, when you sit up, you increase the hydrostatic pressure. A little bit of gravity is helping blood get into the leg. Remember, generally people with arterial disease their veins are fine, so the blood's getting out of their legs, it's just not getting into their legs very well. Ischemic rest pain, in other words, your foot's dying, it's gonna hurt. Non-healing ulcerations. Yeah, I don't think that's going to heal anytime soon. And this person does have gangrene. Oh, I felt my foot stink. Okay. In generally, when we're looking at legs, let's see, arterial, insufficient blood supply to area causing ischemia. Vascular insufficiency, uncontrolled blood sugars, diabetes mellitus, limited joint mobility, improper footwear. Wow, improper footwear causing this. Well, I tell you, you know what? I discovered in being a vascular tech, I understand why. Everyone will tell you who goes skiing that the reason why your feet get so brutally cold sometimes is because you're wearing too many socks and you sweat, and then the sweat got cold, and that's why you're cold. That is wrong. I've heard that a million times. That is not what's happening. Your feet get very cold, especially if you're wearing ill-fitting boots. I discovered that if I tied my boot tightly across the bridge of my foot, or basically where the dorsalis pedis is, that my foot would go cold. Well, yes, because I'm cutting off half the blood supply to my foot by cutting off the dorsalis pedis. So improper footwear and snowboarding does not work out. Characteristics: punched out appearance of this. So this is the wounds, the non-healing wounds. Smooth edges, pain at night, and relieved by elevating leg. No, they made a mistake here. They made a mistake here. You don't elevate your leg when you have arterial issues. You elevate your leg when you have venous issues. So that this is on the wrong. So just remember that is wrong. Because if anything, you want to dangle your legs off the side of the bed in order for blood to get into your feet. Usually occurs on the lateral foot. These are ulcers here. Lateral foot, but can occur anywhere in the lower legs. The lower extremities are cool to the touch. Well, because you're not getting blood to them, so they're cool. Pale, shiny, thin skin, no hair. If you're not feeding those hair follicles, they will not grow. Minimal drainage from wound, because your whole leg's kind of dry, actually. And venous is more pooling of veins, of blood in veins. DVT, varicose veins, incompetent valves, which is the same difference with varicose veins. Muscle weakness. Muscle weakness. If you don't have a muscle pump, if you don't have a calf pump getting blood out of there, perhaps for paralysis reasons, you're gonna have venous stasis, immobility, pregnancy. The wounds are shallow and superficial, irregular shaped, painful from edema, phlebitis, or infection, just all over the lower legs and ankles. Ugh. You see the discoloration in that leg there due to blood and blood proteins being squeezed out of the veins and into the interstitial spaces, and not being able to get back into the veins, for squeezed out of the capillaries and then not being able to get back in to be reabsorbed. So bad times. I mentioned the other day blue toe or trash foot. This person has an upper extremity version of that. It's actually called Berger's disease. But thrombosis in arteries is kind of uncommon, but if flow is restricted to the point of stasis, it can happen. It also can happen with, I will add, aneurysms. Aneurysms, even though they're arterial, they get thrombus in them because the blood practically comes to a stop. At least around the edges it does. thromboemboli can cause blue toe syndrome. And then we have Berger's disease. We'll talk about this next chapter, actually. Thromboangiitis obliterans, inflammation of small and medium-sized blood vessels, usually presenting with blockages of the arteries to the feet and hands, and almost exclusively in smokers. Smokers are pretty much the only people who get Berger's disease. I can't. Okay. Oh, JP has a different type of Berger's disease, but that's just junk food. Okay, pathologies, Raynaud's. I mentioned this with my daughter has Raynaud's, and her toes do look just like that. It's like horrible, not very comfortable either. Raynaud's is spasm of the arteries, causes episodes of reduced blood flow, often triggered by cold or emotional stress. With my daughter, it's pretty much just cold. Idiopathic, meaning we usually don't know what's going on, but it can be from injury, like if you're SpongeBob using a jackhammer, or connective tissue disorders. So my daughter had to be tested for connective tissue disorders because of her Raynaud's syndrome. Of course, it's the one where you could test it by putting PPGs on the fingers, putting their hands in cold water, pulling them out and seeing how long it takes to come back to normal. I don't know. If you put your hand in cold water and your hand turns white like this, do you really need a PPG to figure out what's going on? But anyhow. Atherosclerosis, #1 cause of peripheral arterial disease. Oh man, I had another version of this that I was going to use, and I took away the Mexican food because I used to mess with my old classes a lot. But you know, sometimes at some point I'm going to insult somebody. So, but honestly, to be perfectly honest, yeah, Mexican food. A lot of it is pretty bad for our arteries, but it's so good. Oh my God, it's so good. But just let's see, smoking, obesity. Let's see, causes of atherosclerosis, genetic. We just found a little bit on someone who's extremely healthy, but genetically they are predisposed. Hypercholesterolemia, which hypercholesterolemia usually means that there's something else going on that causes the cholesterol. It's not simply, not everyone watches, not everyone, but some people watch their cholesterol intake, and cholesterol is a completely normal molecule. It's a completely useful molecule. There's usually something else going on. It's not so much your cholesterol intake, but I don't know. Hypertension causes stress on the arteries. Diabetes mellitus, they have issues with sugar. Sugar is not good for your vessels. As much as we love to eat it, diabetes mellitus, the sugar is actually very bad for the tunica intima of your vessels. And so obesity in general, hyperlipidemia, so just too much fat, and tobacco use. Tobacco also is bad for your vessels. Atherosclerosis is a reaction of the body to damage. It is not just lipids and cholesterol sticking to the sides. That's not what it is at all. It's an active process. It's a living process, and it's usually from some kind of damage to the arteries. Doesn't happen in veins, only arteries. The life cycle of atherosclerotic plaque. So endothelial, tunica intima injury, smoking, sugar, high blood pressure. Cholesterol is carried by LDL. We hear about low density lipoprotein, high density lipoproteins, and the low is bad. The low density lipoprotein gets the blame, but he is only the messenger. LDL carries cholesterol. It's a cholesterol. I believe cholesterol is hydrophobic, so it cannot travel through the bloodstream very well anyway, unless it's being carried by another protein. So that's what LDL is. Deposit on the medial area of the artery. Actually, even cholesterol is not really blamed. It was brought to the site by inflammation and injury to help. Macrophages engorge with lipids and become foam cells. Why are they called foam cells? Because they look like foam under the microscope. Migration of smooth muscle goes into the plaque. Neovascularization, in other words, there is blood flow into the plaque. A cap forms. And then look at these guys. These were all a little happy, and now they've become angry because the plaque has ruptured. Interplaque necrosis, interplaque hemorrhage, and rupture. No. Arterial physiologic testing of lower extremities. Goal of, so this was our last chapter. So we talked a little bit about this. We narrowed down the location of disease by doing these. They're relatively quick, although I hate them. You know what? I hate them because I don't really do them. Even though I had one of these machines myself, at least an ABI machine. This woman here has a 1, 2, 3, 4 cuff method, plus the brachial arteries, and that is all done by the machine. So all you have to do is set it up correctly. The image over here shows, let's see. I'm going to say from the waveforms alone, very mildly abnormal. The only reason I say that, they actually have a nice high peak and they come down. They actually look pretty good, but there's no shoulder on them. There's no, oh God, what's the term? Dichrotic notch. I had to scratch that bald head of mine for a couple of seconds before I remembered that. It's not really showing a dichrotic notch here. But gosh, let me look at these numbers. I really can't. ABI on the right is 0.9. ABI on the left is 0.59. So that's, the left is definitely something's wrong here. That's the overall. Then they kind of have little mini ABIs as we go through, although they're not ankle brachial indexes. They have mini indices here. We look at the blood pressures. Really 225. I mean, that's high. Gosh, her blood pressures is 191 and 184. That's close enough from arm to arm, but overall she's got stinking high blood pressure here, right? 255, artificially increased because the cuff wasn't the right size for her leg. 208, 128. Yeah, well, okay, well, whoa, wait. 225 to 128 for blood pressure. That's a big drop right there. So we definitely have some upper thigh issues going on here. Let's see, coming down, 208, 193, 171, 161, 143. So none of our numbers, except for this 225, which is artificially high, and that's pretty common. These numbers over here, and I hope you can see this, just in case you can't. These numbers, there's no giant drop. So we're looking pretty good. And actually the ABI is normal. I just don't like, there's no dichrotic notch, but you know what? That could just be because cuff needed to be just a tiny bit tighter in order to see that notch. But over here, we go from 225, artificially high, but down to 128. That's a big drop, and certainly across the way here and across the way here. So all the way down from, so right about here, there's something going on somewhere in here, the mid to lower thigh. There is some stenosis going on. Okay, let me move forward. Oh no, okay, yeah, whenever I use this, something goes wrong with the whole machine. Okay, I think we're back. Arterial physiologic testing, lower extremities. PVRs, a pulse volume recording. So that is using a cuff, and the cuff first, that cuff does double duty. It takes a blood pressure, releases, and then it tightens up only like a little bit. I forgot the blood pressure. It was 80 millimeters mercury. It just gets slightly snug, and then and then that way it could feel the heart, and it actually creates waves that look just like this. So those are not Doppler. That is not us. It's not our machine. It's not ultrasound. Segmental limb pressures. That's basically this. That's what we're also doing up here. Segmental limb pressures. ABI. That's just arms and ankles. And stress test to see if things get worse, according to Bernoulli's law. Pulses, we didn't do, no, I don't think our book talked about pulse gradation. This was the old book, but that's okay. We don't really do this anyway. 0 is no pulse. Probably not good. 1 is weak, 2 is normal. 3 is too strong, possibly an aneurysm. Questions, we went over that last time. Are you a smoker, diabetes, blah, blah. Pallor, pain, paresis, paralysis or weakness of the muscle, cold limbs, dependent rhubarb. The parts of the leg that are dependent may become red. Cyanotic toes, not blue toe in the case of a sudden embolism, but more cyanotic as in like, it's blue because there's not enough blood in there. Ulceration, non-healing wounds, blue toe syndrome, that specifically is an embolus. 4-cuff method, 3-cuff method. This person has PPGs, photoplethysmography on the toes. No, he doesn't. That's actually, no, that's a blood pressure cuff. Oh wait, it's both. The wire goes to this black strap here is the PPG. Oh, and this white, I didn't recognize that before. So, okay, so blood pressure and PPG at the same time. Interesting. Not so interesting that I want to do it, but let's see, that's arterial pressures. We could take note. By the way, that is a small continuous wave transducer. So actually, this is a really good point. I'm glad I zoomed in on this. Sometimes you don't have a PVR machine. You could still take the blood pressures using the vascular continuous wave, and then you would report an actual Doppler wave. Do not do brachial pressures if dialysis grafts are present. Pressure difference between the arms of greater than 20 millimeters mercury is trouble, usually a problem in the subclavians. Okay, yeah, this is just talking about, we got some pictures here. Here are pictures here with a dichrotic notch. Let's get my little, let me try spotlight again. Nope, it will not go in. Interesting. Little dichrotic notches. Now, if we could see this in Doppler, yeah, that's triphasic, but the PVR is not that accurate, but it is accurate enough to show a fast upstroke, downstroke, and then this little jump is probably like a reversal of flow. Looks good here too. That looks good. That looks good. Just a tiny little dichrotic notch. That's all you need though. And that looks good. Let's see what our numbers are. 0.9. Oh, we only have pressures on this side. 122, 150. Probably a little bit increased, but 139, 103, 132. Oh, because it's deep dorsalis pedis and posterior tib, and then 115 all the way down in the toe. And for some reason, we don't have all of our millimeters of mercury. Why is this 69 millimeters mercury highlighted? Just because it's 69? The guy thought it'd be funny. And why do we have 67 millimeters mercury here and 150 here? At least this doesn't all go together. Oh, I'm sorry. Okay, see, the PVR pressure is 67, because I was going to say that's really low, right? PVR pressure is 67. So in order to get this waveform, the pressure was at 67. The reason this is red, I bet you, is because just like our angle correct, it turns red when we're a little bit out of range. Or as soon as we're out of range, when we go past 60. I bet millimeters of mercury, maybe this is just a tiny bit too tight. And the machine is telling us that's a tiny bit too tight. Okay. These I gotta get rid of this thing again, apparently. Okay. No dichrotic notch. Let's see. And our ABIs are low, 0.5 and 0.26. So we have disease on both sides immediately, all the way up from the top. Yeah, it's not showing. It's showing all the PVRs, but not all the pressures for some reason. But right from the beginning, there's some problems. So it probably has some aorta or an internal iliac issues bilaterally. And then as we go down the leg on both sides, it gets considerably worse at some point. The big, let's see, right ankle, left ankle. I'm really not sure why the right big great toe is larger waveform. Okay, lower extremity, performing the exam, it's a good idea to find the ankle pressures first, taken instantly. Incidentally, pressure recorder is not where you have the stethoscope or Doppler, it's at the cuff. So pressure is always, the pressure measured is always under the cuff, no matter where you actually take it. Oh, I think I drew this one out for you guys already. You see that? Note on the previous page, if ABI is greater than 130, then the arteries are considered incompressible, uncompressible. Uncompressible arteries have calcified walls. And you can see this artery, and you will see this, guys. The entire, like this is the ATA, the entire artery is filled with, or wall is filled with calcifications. Generally diabetic patients, and if you really need a pressure, a toe pressure, because by the time you get to the toe, there's no more calcifications. Stress testing, so we could force them. I don't know why. Oh, I know why. So this is an ABI, basically, or just actually an ankle measurement of Oh, well, it is an ABI because there's brachial here. You need to see my, okay. Right ankle, left ankle, brachial. So let's see. Right ankle is the box. Left ankle is the circle. Boom, 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 boom. And brachial. So the base looks like it was, let's see, around 150 for the brachial and the person exercised. Pressure went up a little bit, and then it came down. It actually came way down. So I actually cannot explain. I don't know how to explain why the brachial artery came up a little bit and then down, 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 down. But the important part here is the ankle. This ankle under exercise stress or after exercise stress dropped from 140 to 97. 140 to 97. And then it took time to even get back to 109. It's still, we would have to wait for it to come back. This person ended the exam at that point because it's like, we already know what the result is. There's something going on in the left ankle, especially after exercise. I gotta do this again. Okay. This is why I just hate PowerPoint. All right, Doppler waveform. So yeah, Doppler may be used in subsequent or even in place of PVR and ABI studies. However, insurance may require at least a abnormal ABI prior to a Doppler study. So that is one reason why an ABI and why I bought an ABI machine is because for insurance to pay, sometimes they need to see that easier exam was done first. I think that's kind of stupid on insurance's part, but let them do what they do. Daigle says use a continuous wave, although I've always used a linear in the past and it worked just fine. There I am. No, that's actually not me. I guess there's no reason for that picture other than the fact that he's bald. Normal and abnormal PVRs, not Dopplers. So, okay, we don't get a dichrotic notch like this very often, but we do have a sharp peak and a rapid upstroke. And then when we look at the other side, let's get my little annotation back here so you can see what I'm looking at. Rounded peak, basically, PVRs will show a tardus parvis. It will show a lack of triphasic flow because there's no shoulder or no dichrotic notch present. Ooh. So let's see. Normal. I go straight to, damn it. Annotate. I go straight to here. Ankle brachial index, that is a normal range. I look at these, dichrotic notch, sharp upstrokes, all the way down. PPG, that's a PPG, don't worry about it. Don't worry about the lack of dichrotic notch on this one, it's a PPG. That looks great. Ooh, this one is a Doppler. It is a continuous wave Doppler and a simple, what am I doing wrong? It is a simple Doppler, a simple machine, not nearly as complex as our machines. So these Dopplers aren't beautiful, but it does show triphasic flow. This is a continuous tracing, by the way. Triphasic. Triphasic there, and PPG. 0.98, 0.94, so that's going to be, yep, those are all good. Trying to go through this fast, guys, because I know that, ooh. All right, well, you don't have labs, so. Doppler analog, okay, oh my God. So an analog Doppler is even more simple. It's basically it's not even a digital Doppler, but let's see. Oh, ankle brachial index, the number all the way down on the bottom for the left leg is 0.57. So that we know something's wrong. 0.96 on this side, so that should be normal. Let's see what happens right from the start. Right from the start, there's a problem, and it seems to get worse. Let's see, blood pressure, 96, 88, 80. Well, certainly it would appear that the left iliac artery is the major problem here, because right from the start we've had problems. So it could be proximal femoral, really proximal, right up in the groin, or the iliac artery. PVR, so not Doppler. This is the machine doing all the work for us. 0.96 on the right, 0.57 on the left. And once again, this might be the same patient because it is right from the start, something is wrong. You know, when you look across the legs, if you look at blood pressures from left to right, right to left, you see there's something going on there too. So that's probably another left iliac issue. Oh my God, what the hell is this? Right leg normal, even though triphasic not seen. Yeah, left, what is this, a spectral Doppler and forecuff pressure. So we have a pressure machine, but we don't have a PVR. So they had to use Doppler, handheld Doppler to do this. Left common is abnormal. Everything below the common is abnormal. Let's see, 180, 100. Oh, okay, so common, I see common femoral. Right, because you wouldn't be able to do that with a PVR. And with the spectral though, you're able to get pretty high up. They got a common femoral artery that looked good. And then soon after, a superficial femoral, now known as simply the femoral, is abnormal. It's tardus parvis, and there's no reversal of flow. I see what, yeah. Let's just skip this one. Duplex imaging, used as an adjunct, provides beautiful pictures, yes. Common femoral artery bifurcation there. Placement of the spectral RI does not correspond well to the color image. So you could see down here on the left that we had Kurt Schellenbeck. You know what? That must be editing. Oh, there it is. X mark. All right. That looks like a stenosis. What's the speed? 327 centimeters per second. Well, they put it all the way up here. Kind of numbnut would do that, but anyways, we know it's high. And suddenly down here, velocity B is 57. So this was velocity A. And then what they did, without changing the picture, they just rolled this back and found, I'm sorry. Yeah, velocity A. And then back here would be, looks like velocity B. So that's kind of pre-stenotic ugliness there. Okay. Oh. So duplex, not the first choice because it's time consuming. Depending on your facility, you will start at the, with the aorta or at the external iliacs or the femorals. Deep profundal artery is the exception. Oh, yeah, I'll talk about that tomorrow. Deep profundal artery. Sometimes we use a curved transducer. beautiful femoral artery at that point. Actually, yeah, it's just the femoral. Popliteal. There's a great picture of the anterior tibia going anteriorly. But wait, Kurt. I'm sorry. Wait, Mr. S, my awesome teacher. Why is it, if you say it's going anteriorly, why is it going down on the screen? Because your transducer is upside down. Remember that. Tibs, that's the greatest picture ever. Yeah, that's more of a shortcut. Of course, if you had a reasonable doctor, you could have started at the DP and PTA and possibly ruled out the entire exam to begin with. Tips, pay attention to the whole screen. If there's DVT in the associated vein, we don't want to miss it. I saw a guy do that and he got fired because it wasn't the first mistake he made. He made lots of mistakes. Here he is doing an arterial exam and there's a gigantic DVT and he misses it. The guy was an idiot. Perhaps use live color Doppler and spectral at the same time if certain segment of artery is suspicious. You could inch your way through the artery, but your frame rate will suffer. You can jump to the, in other words, why is everything getting darker? Stop it. Stop. Okay, why are you getting darker? I don't understand. Okay, I guess it's because the sun's going down outside and someone set this machine up. Perhaps use, you can jump to the next section in artery if that jump reveals normal flow. So if you're seeing normal, you don't need to be super careful. I mean, I hesitate to say that, but what I'm saying is if it's normal and then you take, let's say, a 6-inch jump and that's normal, you don't need to, don't worry, just you're fine. But if you take a 6-inch jump and suddenly there's a big difference in the waveform, you missed something. Now you have to go back. Other things to look for. Okay, we're almost there, guys. Aneurysms, lower extremity aneurysms, iliacs, common femoral, popliteal. Aneurysms can cause problems. They can cause blue toe or trash foot. Fun. Pseudoaneurysms. If you know the person has recently had a needle stuck in them, they perhaps have a pseudoaneurysm. So an AV fistula. I have a little graphic where this comes down and sticks through the artery and the vein. So the doctor has put a needle in, got a little aggressive, and went right through the artery and into the vein, causing an arterialized flow in the vein. I know I'm flying right now, but this is getting long. And I didn't clock in. Crazy case with both a pseudoaneurysm and a fistula. Oh my God. They went through the artery and the vein. They caused a pseudoaneurysm and a fistula. Here, let me make sure you see what I'm talking about here. Zoom. Pseudoaneurysm, artery, fistula, vein. So this artery is feeding both the pseudoaneurysm and putting arterial blood, arterialized blood in the vein. Yikes. Oh. Well, there's only 4 more slides. Autologous grafts, meaning kind of like you're using your own body for a graft. Reversed great saphenous vein. Yank out that vein. Of course, you've made sure that you show the doctor all the major tributaries so they can tie them off first. Expose a healthy artery proximal to the occlusion disease. Connect the distal end of the vein segment to the proximal artery. Connect the proximal end of the vein segment to the distal artery. In other words, you're bypassing a diseased portion of artery using a vein. The valves are pointed in the correct direction, so you don't need a valvulotome. Disadvantage, major surgery causing disruption of the vasovascular and many more issues. In situ great saphenous vein bypass is where you just simply take the vein, kind of plug in the proximal to the proximal and the distal to the distal. You bypass that artery where it was diseased, but now you have all these, excuse me, now you have all these valves in the wrong direction. So if you look closely in that vein, a valvulotome is being sent up through there, and it's going to come back down, ripping all those valves out, probably causing a lot of bleeding, but who would know? It's already inside of a vein. Imaging, yeah, and mapping, yeah. And that's it. That is it, guys. I know this was longer than I meant it to be. Sorry. Hopefully you aren't crying right now from complete boredom. All right, we'll see you.